In this video, we will talk about how to take gynecology history in a structured manner. Do note that gynae history requires sensitivity and confidentiality is important. We also have to ensure the dignity of the patient, and this should be communicated to the patient. Possibility of pregnancy should always be considered, especially when there is history of abnormal bleeding or pain, although the patient may not bring this as a diagnosis. The history-taking sequence is similar to the structure of a medical history-taking. Areas that would be covered include history of presenting compliant, a detailed menstrual history, review of associated gynecological symptoms such as vaginal discharge, urogynecological symptoms, and pelvic abdominal mass. Women history components including cancer screening and sexual health and use of contraception would also be covered. This is followed by a past history which includes the past gynecological, obstetrics, medical, and surgical history. We would then complete the history taking with family, drug, and social history. So firstly, we will consider menstrual history in detail. There are 6 parts to a detailed menstrual history by asking for menarche, cycle length, bleeding duration, bleeding amount, and associated symptoms such as pain, vaginal discharge, and irregular bleeding. An easy way to begin is to ask patients to tell you about their menses, followed by asking for the specific details. Firstly, for menarche, you could ask when did the patient first get their menses. This is of greater relevance to younger patients. For the cycle length, you can ask when was the first day of their last menstrual period, and if it arrived at the expected time. Questions like, are your periods usually regular or irregular? How many days are the cycles usually can also be asked. Periods are considered normal between 21 and 35 days. If periods are very frequent, less than 21 days, it is known as polymenorrhea. If periods are infrequent, more than 35 days, it is known as oligomenorrhea. Oligomenorrhea means infrequent periods with a cycle of more than 35 days. If the patient's menstrual period is irregular, it's important to ask specific questions related to an ovulation. The first question would be about any recent weight change. Excessive weight loss or weight gain is important. Weight loss in athletes or in people who exercise heavily and in girls related to anorexia nervosa may lead to hypothalamic suppression and hence amenorrhea or oligomenorrhea. Excessive weight gain is often related to polycystic ovarian syndrome, which is also associated with anovulation and oligomenorrhea. Polycystic ovarian syndrome is also associated with acne and greasy skin or abnormal hair growth, for example on the chin or on the chest or other facial areas. It is also important to consider that it would be hyperprolactinemia. We need to ask the patient about galactorrhea, if there is any discharge from the breast or nipple or recurring headaches, as this will require specific investigations including hormones and imaging. Hyperthyroid symptoms are also important and should be inquired. Not to forget menopause. Although menopause is expected in the late 40s or early 50s, it is not uncommon to have premature menopause in women younger than that, and therefore one should always inquire about hot flashes and night sweats. Amenorrhea. On the other hand, missing periods are known as amenorrhea. Amenorrhea can be categorized into primary or secondary. Primary means menstruation has never been established.
If the girl is 16 years old with secondary sexual characteristics and never had menses, then she suffers from primary amenorrhea.
The other way to define it is when she's 14 years old but does not have any secondary sexual characters. This would also be diagnosed as primary amenorrhea. While secondary amenorrhea refers to the absence of menses for more than 6 months in continuation, it's important to remember that the most important cause of secondary amenorrhea is pregnancy. So the first step would be a pregnancy test to exclude that cause. It is worrying if the patient is bleeding excessively, which may be a case of menorrhagia. Hence, we assess this by asking about the bleeding duration and amount. For the bleeding duration, count the number of days the patient bleeds. The normal duration is 3 to 8 days. It is also important to ask about the progression of the flow across the days, as there is a difference between 7 days of full flow versus 7 days of decreasing flow. Normally, menstruation will be heavy for day 2 or day 3 and then becomes less frequent to last for a total of about 7 days on average. For bleeding amount, some questions that can be asked are: how frequently do you change your pads? Was your pad completely soaked? Was there any clots or flooding? If they do not understand the term clots, you can ask whether they passed any tissues or liver-like substance, and if so, how huge are the clots by comparing against size of coins, 5, 10, 20 or 50-cent coins. Also ask if there has been any accidents of soaking through all protection, such as clothing or bedding, and if the patient has to get up more than once to change her pad at night. Ask if the period interferes with normal life or duties, such as school or work. These are all signs of an excessive menstruation or menorrhagia. Excessive bleeding can lead to complications such as iron deficiency, anemia, and hence we should also ask for signs of dizziness, shortness of breath, and fatigue. Menstrual history also includes whether the periods are painful, which can be a sign of dysmenorrhea. Follow-up questions include timing of the pain, can give you a diagnosis if it is primary or secondary dysmenorrhea. It is considered primary when no significant cause or no organic cause for a disease is found. It usually begins with beginning of bleeding or menses, lasts for first 2 to 3 days, and usually improves once the girl matures or has children. While secondary dysmenorrhea refers to secondary to a pathology such as endometriosis, fibroids, or chronic pelvic inflammatory disease, the pain usually begins few days prior to the menses and gets better once the bleeding begins. It is also important to ask about severity of dysmenorrhea: mild, moderate, or severe. Severe dysmenorrhea will affect a patient's lifestyle, leading to time off work or school required. Is this a recurrent feature would also be an important question. It is also important to consider any aggravating or relieving factors of a disease. Do they take painkillers? If so, do they take it regularly, and does it make the symptom better? Is an important thing to consider. It is also important to ask about family history of conditions such as endometriosis, as endometriosis is known to run in families. The last part of the menstrual history is to ask for any abnormal bleeding such as postcoital bleeding and intermenstrual bleeding. Postcoital bleeding refers to bleeding after sex, which can be an important sign of cervical cancer, or it can often be related to a benign condition known as cervical ectropion. While intermenstrual bleeding can be a sign of infection, it can be hormonal or could be related to polyps. Hence, it's important to establish whether it's cyclical or non-cyclical. Vaginal discharge, an important topic at the gynecology clinic, can be categorized as physiological or pathological. To differentiate between the two, it is essential to ask specific questions. First and foremost, it's important to determine the duration of the discharge. Additionally, one should ascertain whether the discharge is cyclical, meaning if its amount increases during a particular phase of the menstrual cycle. It is worth noting that during ovulation, the discharge tends to be thin and mucousy, while closer to the start of menstruation, it becomes thicker and whitish. This hormonal variation is normal. Furthermore, any accompanying symptoms related to the discharge, such as itching or odor, need to be documented. The quantity of discharge should also be noted. The color of discharge can provide diagnostic clues. For instance, yellow or greenish discharge may indicate an infection, whereas brown discharge suggests the presence of old blood. Regarding odor, a physiological discharge typically does not have a strong smell. However, in the case of bacterial vaginosis, the odor is often described as fishy. Recurrence of the symptoms or a history of previous episodes is important to ascertain. It is also crucial to inquire about any treatments used, as recurrent causes of antibiotics can sometimes lead to thrush or incomplete resolution of infections. In addition, the presence of other symptoms such as pain or fever may indicate pelvic inflammatory disease, an important cause of vaginal discharge. Considering that sexually transmitted diseases are a common cause of vaginal discharge, obtaining a comprehensive sexual history is crucial. Sexual history can often be intimidating. It's important to approach it in a sensitive and structured manner. An easy way to begin is by telling the patient that you need to ask them some personal questions. The patient may have never been sexually active before. Hence, one should begin with, "Are you or have you ever been sexually active?" It's important to know the age of first intercourse. Therefore, this should be documented. It is important to inquire about how many partners they have had in the last 6 months, as having more than 2 partners in the 6 months increases the risks of having a pelvic inflammatory disease. Asking about their most recent intercourse is an important leading question, as this will give you an idea of the chances of pregnancy and the risk of pelvic inflammatory disease. It is also important to document the type of sex and the use of any contraceptives or protections. It's important to know whether they have had any sexually transmitted infections in the past or they've had any sexual assault or incest. Another important point to consider is domestic violence. Therefore, this should be questioned when appropriate. Patients may present to you in the clinic with a mass in the abdomen, so let's see what questions we need to consider. For how long has this mass been present? Has there been a change in size? Has it increased recently? Is there any associated pain or tenderness? Does it hurt when you touch the area? Are there any associated symptoms such as nausea, vomiting, or recent constipation or diarrhea? Ask about weight loss and appetite, as that can be associated with malignancy. Other symptoms to consider would be heavy menses or amenorrhea. Heavy menses with a mass would be a feature of fibroid, and amenorrhea can be related to a pregnancy, which can often present as mass. Let's talk briefly about urogynecological history, which includes the urinary symptoms, bowel symptoms, and signs of prolapse. An easy way to begin is by asking the patient if they have any problems passing urine. Common urinary symptoms include urinating frequency, getting up frequently at night to pass urine, pain passing urine, any urinary incontinence, and also blood in the urine, etc. Incontinence has to be defined in terms of whether it is related to stress or urge, which carries different diagnoses. Hence, ask about stress urine incontinence. A good way to begin is to ask if the patient leaves urine when they don't intend to, and if it's related to or provoked by certain acts, such as coughing, having sex, or heavy exercise. This is a feature of stress incontinence. Urge incontinence is related to aging and usually found in postmenopausal women. A good way of questioning is to ask if the patient has made it to the toilet in time or if they can hold in urine without leaking. Another way of questioning is to ask if they pass small volumes of urine quite frequently. The patient may also present with a mixed picture and may require further investigation. Another presentation of urogyne is prolapse. It's important to ask about symptoms related to vaginal discomfort, feeling of a lump or something coming down, especially after exercise or heavy work. Screening questions for any bowel symptoms such as bleeding PR, fecal incontinence, bowel habits, mucus in the stool, and difficulty emptying bowels may have a bearing on the gynae diagnosis and are important to consider to complete the total gynae history. Cancer screening is an integral part of the gynae history. One should always ask about the date and the result of the last cervical smear and mammogram, or any treatment related to colposcopy or abnormal pap smear in the past. Also asking if they have taken any of the HPV vaccine, the duration of it, and when was the last injection taken would be important. Contraception is also very important. Therefore, it's important to know about current as well as past contraception. Any abnormal or irregular bleeding may be related to progesterone contraception and should always be asked about. Therefore, it's important to know whether the contraception is hormonal or non-hormonal. In non-hormonal contraception such as IUCD, it can be related to dysmenorrhea and menorrhagia, and therefore the importance of knowing the type of contraception. Any problems with the current contraception, as they may require a change of contraception or further advice. Let's talk briefly about obstetric history, which will be covered in another section but is relevant to a gynae patient as well. The number of previous pregnancies is important to know and should be documented. It's also important to know the number of children, as some of these pregnancies may either be miscarriages or terminations. Any problems during pregnancy or labor? What was the mode of delivery? Was the labor very prolonged? As prolonged labor and delivery of a big baby can be related to or a causative of a prolapse. Any terminations or miscarriage? If so, what was the procedure? Whether it was surgical or medical, and at what gestation did it occur? And finally, a few other things to consider are previous gynae problems such as sexually transmitted infection, endometriosis, infertility, any gynae surgery, any polycystic ovarian disease may have a bearing on your history and should be inquired about. And lastly, ending your history taking by asking about their past medical and surgical history, drug, family, and social history. Quiz time. Question 1. The following is true about the normal menstrual cycle. Question 2. Abnormal menstrual patterns include the following except. Question 3. A 16-year-old single woman comes to the emergency department because of heavy vaginal bleeding. She has missed a period last month, and this period has been unusually heavy with the passage of large clots. Which points in the history is least informative for a diagnosis?